Welcome to this presentation on rapid sequence intubation, or RSI, and the medications used in this vital procedure. Today we'll dive into what RSI entails, its indications and contraindications, the step-by-step process, the key medications involved, and a real-world clinical case to bring it all together. Let's dive in. Introduction. Rapid sequence intubation, or RSI, is a cornerstone of emergency airway management. It's a technique where we quickly induce unconsciousness and paralysis to secure a patient's airway, especially in emergencies. The goal is to take control fast while reducing risks like aspiration. The process includes pre-oxygenating the patient to boost oxygen reserves, giving an induction agent to knock them out, followed by a neuromuscular blocker to relax their muscles, then intubating, and finally managing them after the tube is in place. It's all about speed and safety. Indications for rapid sequence intubation. RSI is used in several urgent situations. It's critical in acute respiratory failure when a patient can't breathe well enough on their own. We also use it to protect the airway in cases like altered mental status or when there's a risk of aspiration. It helps with procedures needing sedation, like surgery, and in trauma cases. Think head injuries where oxygen is a must. Plus, it's handy for managing severely agitated patients who might harm themselves or others. Contraindications to rapid sequence intubation. Rapid sequence intubation isn't always the right choice. If we expect a difficult airway where intubation might fail, we pause and consider alternatives. Known allergies to our induction agents or paralytics are a no-go. Severe airway obstructions, like from angioedema or tumors, can complicate things too. And critically, we only proceed if we have the right equipment and a skilled team. RSI demands precision. The process of RSI, the 7 Ps. The RSI process follows the 7 Ps mnemonic, guiding us through each critical step for a safe and effective intubation. Let's break it down. We start with preparation, assessing the patient for potential challenges, gathering all necessary equipment, and planning with the team. This ensures we're ready for any scenario. Next is pre-oxygenation, where we deliver high-flow oxygen, typically via a non-rebreather mask or bag valve mask, to maximize the patient's oxygen reserves. This step gives us a buffer during the apneic period. Then comes physiologic optimization. Here, we stabilize the patient's vital signs before administering drugs. Think fluid boluses or vasopressors to counteract the effects of induction agents. Paralysis with induction follows. We administer an induction agent to sedate the patient, followed immediately by a paralytic to relax their muscles. These are given back-to-back for rapid effect. Positioning sets up the patient for a successful intubation. It's all about optimizing the airway view for laryngoscopy. We often use the sniffing position, elevating the head and extending the neck slightly, to align the oral, pharyngeal, and laryngeal axes. For obese patients, a ramped position might be better, where we stack blankets under the shoulders and head to lift the torso. Good positioning can turn a tricky intubation into a smooth one. Placement is the act of intubating and confirming the tube's position. The clinician uses direct or video laryngoscopy to see the vocal cords and slides the endotracheal tube into the trachea. Confirming placement is critical. We listen for breath sounds over both lungs, check end tidal CO2 for color change or for a waveform if available, and order a chest X-ray to verify depth. Depth can also be confirmed using bronchoscopy if needed. This step ensures the tube's in the right spot, not the esophagus. Finally, post-intubation management keeps everything on track. We secure the tube with tape or a holder to prevent it from shifting. Then, we start mechanical ventilation, adjusting settings based on the patient's condition. Each P builds on the last, making RSI a structured, life-saving process. Induction agents. Induction agents knock the patient out fast. Etomidate, at 0.3 to 0.4 milligrams per kilogram intravenous, acts quickly and keeps blood pressure stable, making it a favorite. Ketamine, 1 to 2 milligrams per kilogram intravenous, offers pain relief and can raise blood pressure, great for unstable patients. Propofol, 1 to 2 milligrams per kilogram intravenous, is rapid but can lower blood pressure, so we use it carefully. Midazolam at 0.1 to 0.3 milligrams per kilogram intravenous is slower and less common for RSI but has its place. The choice depends on the patient's condition. Let's look at these medications in more detail. Etomidate. Etomidate is a popular induction agent for RSI because it acts quickly, within 30 to 60 seconds, and doesn't usually drop blood pressure, which is crucial for unstable patients. It works by enhancing GABA, a neurotransmitter that calms brain activity. However, it can suppress adrenal function, which is a concern in sepsis or with multiple doses. It might also cause muscle twitching, known as myoclonus, and some nausea afterward. Ketamine. Ketamine is unique because it doesn't just sedate. It creates a dissociative state where the patient is unaware but may appear awake. It blocks NMDA receptors and kicks in within 30 to 60 seconds. Unlike other agents, it can raise blood pressure and heart rate, which is helpful in hypotensive patients. It also relaxes airways, great for asthma. But watch for increased secretions and possible hallucinations as the patient wakes up. Propofol. Propofol is the fastest induction agent, working in just 15 to 30 seconds. Like etomidate, it boosts GABA for sedation. It's ideal when we need quick recovery, but it can drop blood pressure significantly, especially in dehydrated or unstable patients, and those with reduced left ventricular or right ventricular function. It also suppresses breathing and can burn when injected, so we use it carefully, often in healthier patients. Midazolam. Midazolam, a benzodiazepine, also works on GABA but takes longer, 1 to 2 minutes, to kick in, which isn't ideal for RSI speed. It's more often used for sedation than induction. It can depress breathing and lower blood pressure, and sometimes instead of calming, it causes agitation. We rarely use it alone for RSI but might combine it with other agents. Neuromuscular blocking agents. Neuromuscular blockers paralyze muscles for intubation. Succinylcholine, 0.6 to 1.5 milligrams per kilogram intravenous, kicks in fast and wears off quickly, ideal unless contraindicated, like in hyperkalemia. Rocuronium, 0.6 to 1.2 milligrams per kilogram intravenous, is also rapid but lasts longer, a good alternative. Vecuronium, 0.15 to 0.25 milligrams per kilogram intravenous, is slower and rarely used for RSI. We pick based on patient history and how long we need paralysis. Let's take a closer look at these medications. Succinylcholine. Succinylcholine is one of the go-to paralytic for RSI because it acts fast, 30 to 60 seconds, and wears off quickly. It's a depolarizing agent, meaning it briefly activates muscles before paralyzing them. But it has risks. It can spike potassium levels, dangerous in conditions like burns or kidney failure. It might also trigger malignant hyperthermia, a life-threatening reaction. Though that's rare, you'll see muscle twitches or fasciculations as it starts working. Rocuronium. Rocuronium is a non-depolarizing blocker, meaning it prevents muscle contraction without the initial twitch. It takes a bit longer, 60 to 90 seconds, but at higher doses, it's nearly as fast as succinylcholine. It lasts longer, which is a double-edged sword. If intubation fails, the patient stays paralyzed longer. It's a solid alternative when succinylcholine is risky, like in hyperkalemia. Allergic reactions are rare but possible. Overall, rocuronium is the go-to neuromuscular blocker for RSI in the ICU setting. Vecuronium. Vecuronium is another non-depolarizing blocker but slower, taking 2 to 3 minutes to work. It's not typically first line for RSI because of this delay. It's used more in the OR or for ongoing paralysis. Like rocuronium, it can cause prolonged paralysis and sometimes mild hypotension. We might choose it when we need longer muscle relaxation and time isn't as critical. Comparison of RSI medications. Here's a quick comparison. Induction agents like etomidate and ketamine act fast with different side effects. Etomidate might affect adrenals, ketamine can raise BP. Propofol is the fastest, but drops BP. Midazolam is slower. For paralytics, succinylcholine is quick but risky in some patients, while rocuronium is a bit slower but safer in those cases. Vecuronium is slowest and used less in RSI. This table helps pick the right drug for the right patient. Adjunctive medications. Adjunctive meds fine-tune RSI. Atropine can be used to help with bradycardia, especially in kids. Fentanyl calms the body's stress response, useful in heart cases. Lidocaine lowers intracranial pressure in head injury patients. These aren't always needed, but can make a big difference when they are. Clinical case example. Here's a case. A 45-year-old man with severe asthma, unresponsive to treatment. He's in distress with an SpO2 of 88% on a non-rebreather. Respiratory failure is looming, so we choose RSI. We prepare by checking equipment and briefing the team. Pre-oxygenation uses high-flow oxygen. We give ketamine, 1.5 milligrams per kilogram intravenous, for its bronchodilator perk, and rocuronium, 1 milligram per kilogram intravenous, for paralysis. Intubation succeeds on the first try with videolaryngoscopy. The tube's confirmed with capnography, secured, and we start mechanical ventilation. Complications of rapid sequence intubation. RSI has risks. Hypoxemia hits if pre-oxygenation fails or intubation drags on. Hypotension can stem from the induction agents or starting ventilation. Aspiration's a concern despite our efforts. Failed intubation means switching to Plan B fast. Rarely, cardiac arrest occurs, especially in very sick patients. Knowing these risks helps us prepare. Mitigating complications. We can reduce risks with smart moves. Thorough preparation, gear, and team ready is step 1. Optimal pre-oxygenation with high-flow oxygen and maybe nasal cannula keeps oxygen up. Picking meds that fit the patient cuts complications. A solid backup plan, like extra airway tools, is a must, and constant monitoring lets us catch and fix issues fast. Summary. To wrap up, RSI is a key tool for emergency airway control. It follows the 7 Ps from preparation to post-intubation care. Choosing the right meds for each patient is crucial. Complications happen, but good planning keeps them in check. Always have a backup plan ready. It's a high-stakes skill that saves lives when done right. As we draw this presentation to a close, let us pause to consider the immense privilege and responsibility we hold in emergency airway management. Rapid sequence intubation is far more than a clinical skill. It is a critical intervention that stands at the crossroads of life and death, a moment where our expertise becomes a beacon of hope. This procedure demands not only precision and preparation, but also a deep commitment to collaboration and lifelong learning. Every intubation we perform reflects our resolve to bridge chaos with calm, to act decisively while remaining humble students of our craft. So, let us step forward with purpose, refine your skills relentlessly, unite as a team with unwavering trust, and never forget that in those pivotal seconds, we are the guardians of breath, the keepers of possibility, and the embodiment of care when it matters most. Thanks for listening.